So we treat patients with iliofemoral DVT interventionally, of course, to prevent symptoms in the long term. And so some patients say to me, I don't have that much symptoms, but then when I ask them, they say, yeah, but I don't do sports anymore, or I can't sit through a whole movie, I have to, get up and walk around. And actually, when I go walking for over 10 minutes, then I have to rest in between. And then I say, so you do have a lot of symptoms, but they already adapted their life to it. So of course, if you only treat patients conservatively with stimulating them to exercise and give compression therapy and anticoagulation, of course, not all of them will get post-thrombotic syndrome. So that will help as well. But the problem is, you don't know up front who will get symptoms and who won't. So it's sort of playing Russian roulette. So you have a patient with an iliofemoral DVT, and you can treat them interventionally or you can treat them conservatively. And you have no idea if within 1 or 10 or 20 or 50 years they will get symptoms. So you just say, I have a device, I can help you, but I'm not sure if I will give you the device because maybe you won't get post-thrombotic syndrome or what kind of symptoms if I treat you conservatively.
Mechanical thrombectomy has enabled us to achieve hopefully an optimum patient pathway by allowing us more time to offer these patients intervention. Previously, as we know, with catheter-directed thrombolysis, this only worked on thrombus that's less than 14 days old. Actually, by the time these patients get to see us, their symptom duration is usually at least 2 weeks old, suggesting that the clot is at least subacute, if not chronic, by the time we're actually intervening.
The clot retriever gives the advantage that it doesn't need to be a clot that is like 2 or 3 weeks old. And we often don't know. So patients come to you and they say they have symptoms for like a week. We recently had such a patient, symptoms were like 1 or 2 weeks, but then we found also that she had an obstructed inferior vena cava, which she didn't feel apparently for all those years. Now the new clot she felt. So it's very difficult to define how old a clot is. So for clot retriever, that's a major advantage because it doesn't really matter if the clot is 2 weeks or 6 weeks or 8 weeks old. While when you would only have thrombolysis, then that matters a lot and your therapy will fail. And you don't get the patients always immediately because they're not referred, because they didn't know they had a DVT, because maybe you didn't have the time frame at that moment to treat the patient. So it's an advantage that you have sort of a bigger window for treatment.
Mechanical thrombectomy allows us to review the patients in a timely fashion, but not as an emergency. It gives us time to discuss with the patient the option of intervention, and in potentially mild or moderate cases, we may well elect to treat these patients conservatively for a period of time and potentially bring them back for review in 1 to 2 weeks, still with the option of intervention. If we do want to intervene again in more severe patients with more severe symptoms, we have the ability to plan when that intervention is going to take place so that we can ensure we have operating theatre capacity, ward beds, etc. So it allows us to plan these patients' intervention urgently but not emergently to hopefully optimise their outcomes. It also allows us to not make quick decisions on perhaps more complex cases and allow the opportunity for a trial of anticoagulation alone. And obviously, if the symptoms don't improve or indeed worsen, then we have the opportunity still to intervene to treat these patients. So I think it's important to educate your own colleagues and those around, the referring clinicians as well about what you can offer, because a lot of people don't know that you can intervene for DVT and think that actually anticoagulation, leg elevation is the way forwards. So education is absolutely key. I think having a dedicated team that have an interest in venous work is also important to make sure these patients get the best treatment and best outcome.